Water fluoridation is a classic example of clinical observation leading to epidemiologic investigation and community-based public health intervention. Many research studies have proven the safety and benefits of fluoridated drinking water. From 1966 to 1970, the average number of decayed, missing, and filled teeth among 12-year-olds in the United States declined by 68% after communities across the country started fluoridating their drinking water. In addition to reducing the pain and health problems associated with poor dentition, preventing cavities saves money for both individuals and the healthcare system overall. But unfortunately, while the majority of Americans do still support water fluoridation, it has been the target of conspiracy theories and misinformation for decades. False claims, including that fluoride is a communist brainwashing tactic, that it lowers IQ and causes cancer or Alzheimer's disease, have led some communities to ban water fluoridation. This graph shows the relationship between fluoride content in the public water supply, measured in parts per million, and dental caries or cavities experienced. There's a really clear decline in cavities as the fluoridation increases. One example of a community that banned fluoride in their drinking water is Antigua, Wisconsin. They had started fluoridating their drinking water in June of 1949, but they stopped adding fluoride in November of 1960. After 5.5 years without adequate fluoride, second-grade children had more than a 200% increase in tooth decay, fourth graders had a 70% increase, and sixth graders had a 91% increase compared to 1960. After this impact was realized, the residents of Antigua reinstituted fluoridation in October of 1965 because of the deterioration they had observed in their children's dental health. It's unfortunate that the community stopped fluoridating their water, but an interesting thing from an epidemiology perspective is they essentially did an experiment on themselves. This wouldn't have been ethical to do this to a population of people, but they did it to themselves. Because the same population stopped the public health intervention and then restarted it again, and we've seen this in a number of communities, this provides even stronger evidence to support the safety and benefits of water fluoridation because we can see the change over time as the intervention was stopped and started again. And we know that it can't be explained simply by a change in time across the whole US, because the same difference in dental caries and missing and filled teeth didn't occur simultaneously across the country. It was only in these communities that stopped fluoridating their water. We know that water fluoridation is extremely helpful for protecting against dental cavities and missing and filled teeth. But unfortunately, Alaska has a lower rate of access to fluoridated water compared to the United States overall. You can see specifically the YK Delta and Norton Sound regions have higher rates of tooth loss, and this may be related to their lack of access to fluoridated drinking water. Now we're going to talk about measures of morbidity and mortality. With measures of morbidity and mortality, it's helpful to keep track of what's a rate versus a proportion, and that can get a little confusing. A rate is a proportion where time is always in the denominator, and rates tell us how fast a disease is occurring. The denominator is often person time in epidemiology. It could be person years, person months. You could even do person days, depending on what it is you're studying, but there's always an element of time in the denominator. A proportion is the division of two numbers where the numerator is a subset of the denominator. So that means if you're in the numerator, you have to also be in the denominator. The denominator is usually the total population. So it's both sick and well people, or people who both have or have not experienced the outcome of interest. And proportions are helpful because they tell us how much of the population is affected. Rates tell us the risk of disease, while proportions tell us the burden of disease on a population. Note that for a proportion, such as prevalence, the total population at risk of the condition is in the denominator. There's no unit of time in the denominator. To explain the concept of person time, let's say you're thinking about hiring someone to shovel your roof, and your neighbor says he can do it, but he's just by himself. So it's going to take him 4 hours. And he quotes you a price, and you think, oh, okay, maybe. But you call local company, and they say they can get it done in 1 hour because they have 4 guys who can do the work. So in this example, your one neighbor shoveling your roof for 4 hours versus the 4 guys shoveling your roof for 1 hour. Those are both the same person time. So you would likely end up paying the same amount for the labor, whether you get the one guy for 4 hours or the 4 guys for 1 hour. It's the same with a lot of studies in epidemiology. We're following people through time, and a lot of people don't stay in the study the entire length of the study. So person time is how we count each person, even though their amount of time that they actually are in the study varies. And how we come up with person time is important to keep in mind when you're using rates, because a person who stays in a study for 20 years, let's say, might be different from a person who stays in the study for 1 year and only contributes 1 year of person time. There's different statistical methods that come into play to account for things like that we'll talk about later in the course. Counts are a very simple, straightforward measure. They're just the number of cases. So counts are a measure of disease frequency. Counts are helpful with population health planning and resource allocation, but counts can't compare between groups because they aren't a rate. Rates are good for comparison between two populations or groups. Mortality rate is the number of deaths in a year divided by the population at mid-year. It can be multiplied either by 1,000 or sometimes 100,000. That isn't as important, but it's good to know that usually you're multiplying by one of those two numbers. And when you're reading a report that someone else did, usually they will make a footnote or it will be explained in a sentence. It'll say something like per 100,000, and that tells you what they multiplied by. Mortality is helpful to quantify because it shows the severity of the disease. Note that for cause-specific mortality rates, the denominator is the total population. So that includes both sick people and people without the condition. Mortality rate is a good surrogate for incidence rate for conditions when survival is low. Deaths can be thought of as incident cases because you can only die once, and everyone is at risk of dying who is in the denominator. Infant mortality rate is the number of deaths under 1 year of age during a year divided by the number of live births during that year, usually expressed as the number per 1,000 live births. Note that the denominator for infant mortality rate is live births that year. The whole population is not included in the denominator, only those at risk of infant mortality. For example, a 5-year-old in the population would not be included in the denominator of infant mortality rate because they are already over 1 year of age. Life tables can be used in survival analysis, which we'll talk about a little later on, and they are a way of showing the probability of death over time. This can be helpful for making comparisons between two different populations or between two different intervention groups. Attack rate is the number of people with an exposure who got sick divided by the total number of people with that exposure. Case fatality rate is the number of people who died during a specified period following diagnosis divided by the total number of people with the disease. Case fatality rate measures how lethal the disease is. It's the likelihood a person will die following diagnosis. The denominator is only people who have the disease, not the entire population. Pancreatic cancer would be an example of something with a high case fatality rate because the majority of people who are diagnosed with pancreatic cancer will not survive the year. Here's an example of the difference between mortality rate and case fatality rate. In Alaska, foxes are a reservoir of rabies. It's in the animal populations here. You may have read about some cases up around Nome, and there was a moose that got rabies recently. That's a photo I took of Arctic foxes out on St. Paul Island. There were 25 cases of rabies reported in the US in the past decade, and 1 teenage girl survived. So, rabies is almost always fatal, which is different from measles, which usually causes moderately severe disease. You can see on the right, measles is sometimes fatal, and sometimes people have measles and they have no symptoms at all. But most of the time, people with measles are moderately severely ill. And with TB, it's tricky because a lot of people, most people, more than 60%, don't have any symptoms. So they feel fine, they look fine, but TB can be fatal. You can see it's not as common for TB to be fatal. Measles has a case fatality rate of about 10 to 15%. The case fatality rate is fatal cases among those who have the disease, divided by confirmed cases of that disease, and that provides an index of the deadliness of the disease. Cause-specific mortality rate is the deaths in a year from that cause, divided by the total population at mid-year per either 100,000 or 1,000. For mortality rate, the total population at mid-year is in the denominator. But for case fatality rate, it's the people who have that condition. TB mortality is fairly high because it's so much more common than rabies. Mortality rate is heavily dependent on the prevalence of a disease. And mortality rate is also heavily influenced by the age structure of the population, which we'll talk more about in a little bit. Cause-specific mortality rate for rabies in the US is very low because the numerator is deaths from rabies and the total population is in the denominator. This is in contrast to case fatality rate of almost 100% because deaths due to rabies is divided by cases of rabies for case fatality rate. Cause-specific mortality rates tell us the risk of death from that disease in our population, while case fatality tells us what proportion of cases of that disease are fatal. Here's a few more measures of morbidity and mortality. Years of potential life lost is helpful for quantifying premature mortality. Disability-adjusted life years measures overall disease burden and years lost to poor health. Depression would be an example where a lot of people with depression have many years over their life that are affected by the disease, even though the mortality isn't as high compared to the people who have many years impacted by the disease. Quality-adjusted life years might be used to express the impact on people's lives from a condition such as diabetes, where people are living with the disease, but their quality of life on the day-to-day may be lowered because of their disease. Life expectancy is the average number of years remaining for a person who has reached a given age. On a previous slide, I presented life expectancy at birth, and other graphs may have life expectancy at different ages. You always have to read the graph and see if it's at birth or if it's giving you a different use of life expectancy. I'm going to read each question and then I'll put up the little pause icon so you can stop the video and answer the question on your own and then continue on at your own pace. What was the age-specific mortality from assault for Alaska Native males aged 20 to 24 in 2021? To answer this, we got to read what data is actually presented here. So we have non-Hispanic American Indian or Alaska Native males aged 20 to 24 years. So that's the age group that we're looking for. And we're looking for assault in this age group. So we've got accidents, intentional self-harm, assault. So the number was 32. And then if we go down here, that's where we have to find our age group again. And we're looking for males that are Alaska Native. So there we find 105,952. So our numerator is the number of deaths from assault in that age group. And our denominator is the population during that same time period. So we divide 32 by 105,952, and then we're going to multiply that by 10,000, and then we'll end up with 3 per 10,000. And that is our age-specific mortality rate from assault for Alaska Native males aged 20 to 24 in 2021. What was the age-specific mortality from suicide for Alaska Native males aged 20 to 24 in 2021? You can pause if you need to, but try to go back to the top and find which number you're going to use, and then which number you're going to use from the bottom data. This time we're dividing 61 by the same denominator because it's the same total population in the denominator because we're looking at a mortality rate, and we multiply by 10,000 and get 6 per 10,000.